Mentz. I'm a heart failure cardiologist and trialist at Duke. It's my first time at this meeting. I'm so delighted to be here. Thank you. We did modify this a little bit because what we learned in our discussions coming into this, and we actually agree on so many of the principles. So it's less debate and rather more kind of perspectives. But I'm going to jump right in. I'll start with, these are my disclosures, but I've got to tell you I've got other disclosures too. So my chief resident during my residency, seen here, is the first author of this. All right, that's conflict number one. Conflict number two, many of you were involved in this document, so I'm going to try to be measured and advance discourse and not too much conflict. But actually, my first mentor, also during residency, was part of this. And the first paper I ever wrote, now I'm realizing I need to retitle this. It should have been cardio-kidney syndrome. But Eldrin is there, and then one of my mentees is also. So I'm a little worried that I might upset some folks with this, but I'm going to really try to advance discourse. So just by way of outline, I'm going to go through the aims of this AHA CKM staging, give a little bit of a basic overview, talk about the good, I'll talk about what I'm going to describe as the opportunities, and let's finish positive. So for those that have less familiarity with this, the goals as outlined by the authors were to talk about the clarity of the definition of CKM. I think this is a really important piece of this. This was a gap, and I'll get into some of the rationale around that. Push forth with prevention. Talk about harmonization across specialties, bring in the emerging evidence, including for pharmacotherapies, social determinants of health, and I think they do give a real practical guidance of how can we incorporate this into our routine clinical work to reduce care fragmentation, patient-centered interdisciplinary care. And then actually this last piece to this staging, I think dovetails nicely with a lot of the work we're going to talk about at this meeting. So the authors outline why is this needed. I think this part is really true. There has historically been this silo. We've talked about cardiorenal, cardio-kidney, and then cardiometabolic. And I think this is an example where with the evolution of pharmacotherapies, it's importantly pushed us to really bring these together. So the authors lay out this staging system with obesity at the center. And then they have CKD is the language they're using, CVD, and then diabetes. And they specifically, on the CV side, and this is going to be one of my critiques, I think this is a little too cardiocentric in some ways, but it emphasizes heart failure, I think based on the emerging evidence, particularly of SGLT2 inhibitors, and then now with GLP-1s and the evolution there. And importantly, I think they do pull in that this is not just the at-risk, but also those with existing CVD. And I will admit, before being asked to give this, I had not read this in detail, so you are getting real time, my immediate reactions as I initially went through this. So this is the framework. And at initial blush, I think this provides a helpful context. It has this stage 0, no risk factors. You've got this stage 1. This is a reframing. Their focus here is on obesity or dysfunctional adiposity. I like that. That pulls in important pieces that can vary by demographic, region of the world. Then you've got risk factors. You look, all right, we've got hypertension, diabetes. This makes sense. Subclinical, already noting here, it's really a CV focus, right? So this is saying subclinical CV disease and then clinical disease. All right, initial blush, that makes sense. We go from risk factors, importantly pulling in adiposity, subclinical to clinical. But then you actually look. All right, you got a busy clinic, you're scrolling through this on your way into the office, and you say, all right, actually stage 2 is moderate to high risk CKD. Okay, let's come back to that. So you could have significant proteinuria, significant reduction in your GFR. That's stage 2. Oh, let me go back here. Then you've got stage 3. We got subclinical CVD or risk equivalence. And there's this new risk calculator, which I think advances our discourse in some ways, but I'm a little concerned about the lack of validation for that. But then it's very high risk CKD. And then you move to clinical CVD, and you've got this stratification of whether no kidney failure or kidney failure. All right, this is already getting pretty complicated. All right, so let's start to bring this together. So you've got adiposity. I like that focus. I think that pulls it in. This is clinically relevant. You've got risk factors, hypertension, triglycerides, diabetes, but then they pull in metabolic syndrome, which includes those same components. All right, now we're getting kind of confused as we think about balancing all of these different elements. The only thing you really added was HDL, and now do I have to think, oh, metabolic syndrome is 3 of the 5. And then I think from a cardiologist perspective, I'm a little concerned about some of the language around where they're including in stage 2, this moderate to high risk CKD, this juxtaposition later with no kidney failure or kidney failure with stage 4. subclinical versus clinical. And then now we've got this new calculator. I threw in this great TI-82. I don't know if you all remember this. All right, so best case scenario, maybe this is actually incorporated into your EHR. This could be a great opportunity to facilitate this. It pops up. But my worry, you know what they're going to do at my institution? Now they've got this best practice alert. So Justin's sitting in his clinic. He's trying to close his notes. He's just seen 12 patients. He's trying to get home to make dinner. He's got this best practice. He can't even close his note because this is popping up. Transitioning a little bit, I think the elements that they focus on around this heat map, this advances the discourse for cardiologists. Because we think about cause, we focus on GFR. We do not think about albuminuria. This emphasis is going to be so important as we think about new therapies, we think about risk stratification. And I think they really get it right here, emphasizing cardiologists and broadly, clinicians, we got to be checking this. So I would say if there was one take-home from the staging system, it's actually this element, really from a patient-centered perspective, and they underscore the heart failure piece. I would contrast this with heart failure. I'm a heart failure clinician, and I think this staging system is more clear and directly to the point. We've got at risk, you got pre-heart failure, you got structural functional changes, biomarker changes, but you don't yet have symptoms. Then you've got symptoms, and then you're advanced. And this translates directly to how we think about engaging with our patients, patient-centered care, and therapies. I'm going to be a little critical of this, but I think it actually does advance things in a little way. So this was a companion piece that came out at the same time as this staging with this new risk model. So it's called the PREVENT model. Some strengths, it is sex-specific, it removes race, it incorporates GFR, it incorporates some of these additional measures, it includes heart failure as an outcome, but it has not yet been validated, I think, in a broad set of patients. The proposed clinical application, you screen, you assess risk, you stage things, and then you reduce risk. And they do give these frameworks, as you can think, do we incorporate a protocol into practice? But ultimately, I think you could summarize this with a couple boxes, and I actually worry for the broad clinical community, with all of these details, it just gets completely lost and doesn't give us the help we need rather than specific guidance around medication. So in closing, before I hand it over to the renal perspective, the kidney perspective here, the good. So I think it works to move beyond some of these silos to provide holistic patient-centered care. The risk-enhancing factors, I worry a little bit about the language there a little bit. We've got risk factors, we've got risk-enhancing, but it pulls in high-risk demographics, sex-specific, social determinants of health, and it gives specific guidance around what can I use in my clinic to assess health literacy and other opportunities and barriers that patients may experience. So they give a specific table that I do actually think can be incorporated into practice. They talk about enhanced screening. This doesn't come across as well in the article, but they do talk about this regression, which is certainly our goal. And then some of the bad. So even as a cardiologist, I think this is too cardiocentric. Yes, it's coming from the AHA, and it did include multi-stakeholders during the development of this. But some of the language here, the greatest clinical impact is on the burden of cardiovascular disease. I'm pretty sure if you're talking to a patient that's starting on dialysis, the last thing they may be thinking about is around cardiovascular disease. The greatest clinical consequence is the reduction in survival. I think in heart failure, we've been really fortunate to understand many of our patients, they're not looking for longevity, they're looking for quality of life. The opportunities to identify individuals earlier and focus on the progression, preventing that progression, to CVD, I think it's actually, we need to have that cardio-kidney perspective there as well. And even unfortunately, some of the figures, I think, are overly CV focused and could get lost around some of the language for moderate to high-risk CKD. All right, so you're lucky. I've got a live feed to my institution. This is happening right now on the wards. A clinician's going into the patient's room. Good news, your CKM stage is only 2. Doc, that's great. Bad news, you have high-risk CKD. Wait, what? What are you talking about? And the other clinicians and their family members are around. Do you understand it? Nope. So I think this gives us an opportunity over the course of this meeting to use some of the elements that I think are strengths of this to pull in these elements, the opportunities. Let's talk about social determinants of health. Let's develop further data and incorporate risk models that are not only clinically relevant, but easily evolve into our clinical practice. So in summary, I think bringing this obesity or dysfunctional adiposity in, talking about diabetes, CKD, and cardiovascular disease, advances there. The positives, prevention, social determinants of health, working to reduce care fragmentation and care optimization, but opportunities around the terminology, some of the complexity of this. I think bringing in key stakeholders, the engagement, and needing to validate and make this data-driven. So with that, this was less debate, but more cardiology perspective. I'm looking forward to the meeting together. Thanks so much.
Great, so thanks. As Rob says, this is more of a perspectives from two different places, and so this is the nephrology perspective. So thanks for the invitation, and thanks Nisha and Carolyn for asking us to do this. And we did have the opportunity to go a little bit back and forth with the slides. These are my disclosures. Many of you know that I actually come to them as perspectives. I'm a clinician administrator, and I am a researcher as well, but I've had the fortune and the privilege of being involved in a number of international collaborations, as well as guideline methodology and development, and the most recent KDIGO 2024 guidelines has been a labor of love with the KDIGO team, but also very interested in patient-oriented research paradigms and how we actually are really here to help the patients do things better and be better. So the overview that I'm going to do is the perspective of people living with kidney diseases as well as nephrologists, and then maybe talk about the purpose of a staging system, a little bit picking up on Rob's themes, and then differentiating between what's classification, staging, and risk prediction, and then asking ourselves what problem are we actually solving, and then really thinking about an integrative framework. So people with kidney diseases are complicated. They have complicated physiology and pathophysiology. They have multiple drug reactions and interactions of drugs and differential drug binding depending on where they are in their stage of accumulation of toxins. And they have complex interactions, not just with the healthcare system. They see multiple specialists. They take many medications. Many, but not all, are anxious, depressed, and truly overwhelmed by all the things that we're telling them and talking about. And they watch their numbers on the lab tests incredibly closely. And most are really afraid of needing to start dialysis, and that's what actually drives them, and many other things as well. Now, nephrologists are a diverse group of specialists. Most of us are pretty interested in the complex physiology, and that's what got us here. We're often risk-averse and very conservative. We're worried about the side effects of medications and understanding disease processes, and we're accustomed to having lots and lots of numbers, and up until recently, we weren't very accustomed at all to having a lot of trial data to inform our decisions, and so we're excited in this new world. We've also spent a long time developing and validating eGFR equations, developing and validating a staging system for CKD, importantly emphasizing a need for establishing the cause of CKD, because it isn't just a thing, and developing and validating risk prediction equations for kidney as well as different outcomes. And so if I think about the history and the intention of staging, it was first started in 1929 by the World Health Organization and introduced the concept of describing a disease by stage or extent. It was first applied, interestingly, to cancer, and cancer of the cervix was the first one described. And the purpose is to have a common language that helps us as medical professionals communicate information about a disease to others. And very overtly, in the definition, the disease can be acute or chronic, and they're listed here. CKD doesn't make the list when you look it up. Now, these are essential tools in clinical medicine that provide us a valuable information for patient management and research. They're used across medicine to measure disease severity, patient prognosis, and maybe, ideally, also to determine eligibility for clinical trials and guide clinical care. They're supposed to provide us a model for the natural history of a disease and a framework in which to validate new biomarkers or test new interventions. But they require an ongoing effort to look at standardized terminology so that we're better communicating and understanding, not just across the medical community, but with our patients. And Rob's already alluded to some of the problems that we have. So it's a shorthand method for describing the disease. It's usually coded in numbers. It's a grouping of cases into broad categories based on extent of disease, and I want you to reflect on what you just heard and think about how well that does or doesn't work. And it was initially intended to be an extent of an anatomic categorization for descriptors. Now, contrast that with classification. Classification is the process of grouping cases based on specific criteria, and that's an orderly arrangement that shows the relationships among groups. It doesn't always imply a prognosis. And then you have a relationship between staging, extent of disease, and classification that's written here, usually based on a human anatomy, and usually the classification is based on individual case, and staging is the coded shorthand that helps describe the disease in a more general term. And so it's important that we understand these when we try and think about what the key characteristics of a useful clinical staging system is. It has to be clinically relevant and directly impact patient management and treatment decisions. It has to be customized based on specific disease types and patient populations. It offers you ultimately a comprehensive medical summary. It should be able to incorporate pathological information so it improves the precision of it. It needs to evolve and have periodic revision. And lastly, and very importantly, it has to be very straightforward and easy to use for clinicians, researchers, and patients, and it needs to be accessible to them. So what do we know about CVD and CKD, and how does this current staging system actually help us? Well, this audience well knows and has seen this diagram in multiple other versions that chronic kidney disease progression is driven by combined effects of metabolic, hemodynamic, inflammatory, and fibrotic factors, which ultimately lead to kidney fibrosis and kidney progression. And those are actually similar processes that impact cardiovascular disease. We also know that cardiovascular disease is prevalent in people with CKD and portends a high mortality, and there's various ways that this has been demonstrated. And most recently, and I think this is important, some of the nuances of this heat map that the CKD-PC and Morgan Grams, our co-chair, is the first author on this paper in JAMA last year. This is the different relative risks for different cardiovascular outcomes by eGFR and urine ACR. On your left panel is under 65 and the right panel is over 65. Basically, it takes away the age problem if you use the combined GFR, creatinine, and cystatin, eGFR equation. But the important thing here is that whether you're looking at myocardial infarction, stroke, heart failure, atrial fib, or peripheral vascular disease, you have different risks depending on these constellations, highlighting that cardiovascular disease is also not one thing, but these different outcomes can be impacted by different stages of kidney disease. You've already heard that there's a complex physiology of cardiac and vascular diseases, and I use that word again, diseases in kidney disease as well, that actually are attributable to traditional risk factors as well as novel risk factors that many people have spent a long time reviewing and discussing. But basically, you can have a dilated cardiomyopathy, you can have coronary artery disease, you can have vascular disease, you can have dysrhythmias as well as LVH. These are not all the same condition and don't portend the same prognosis for people. And the complex interactions of over the life course of an individual impacted by hormonal status, age, and other things, as well as social determinants of health, is also really important. And so this is a complex system that we're talking about. And that complex physiology might actually explain the differences in rates of different cardiovascular conditions in chronic kidney disease, be that heart failure, CAD, or stroke. And this is a paper by Nisha that looks at the absolute rates of these three conditions in community-based cohorts, again, by kidney disease and no kidney disease, with kidney disease in the light blue. So different prevalences of different conditions by kidney diseases. And this nice summary paper by Dr. Flöger and others looks to, again, delineate the contribution of the different traditional and non-traditional risk factors, but hasn't articulated the relative contribution to atherosclerotic disease versus heart failure. And I think that as people who like precision as well as understanding the physiology, we do need to do some of that differentiation. And when you look and we see all this huge amount of sudden death for people on dialysis, we often talk about what that's attributable to is probably the disproportional the combination of electrolyte disturbances leading to dysrhythmias with or without fibrosis and or atherosclerotic disease. But again, we haven't actually investigated this as well as we should have for something that occurs quite often in our dialysis population. This is a paper by the Spanish group looking to understand the contributions to atherosclerotic events by specific processes, looking at different levels of things like FGF23 and clotho and phosphate and 125. But these are all attempts at understanding one process in a variety of processes. So there are now new paradigms and models for risk prediction, and you'll hear more about that from Dr. Koresh and others, but this is changing our care patterns and trying to integrate new models, and I think this is all very valuable. And in that paper that we're looking at, the CKM, the scientific statement, there's an acknowledgement of the complexity, and I'll say that this diagram actually isn't linear and acknowledges the interactability and the circularness of the conversation that we're about to have for the next 2 days. And then to go back to these stages of CKM, they describe the processes and syndromes in a very linear manner, and I'm not sure that that is necessarily what we see or usable. And then this is the table that's in the paper that Rob and I most recently read. But it describes the characteristics of the different risks. It uses all sorts of different types of information, imaging, history, lab data, some of it specialized testing, and some of it common, risks and risk equivalents, events, and there's a whole bunch of and or. So I'm really not sure what the clinical utility is of this staging system. So to conclude, if I think about the statement that we were given, does this new AHA CKM staging solve all of our staging problems, and should it be applied universally? Well, first of all, I wasn't sure what problem we were trying to solve with the new staging system. I didn't know that we had a staging problem. I think we might have an awareness problem of the complex physiology and identifying gaps in our knowledge. And I do think that we have a problem with integration of strategies to identify care and enroll into clinical studies. But I don't think we have a problem with the staging system. There's a lot of things that we don't know. We don't know the relative importance of different risk factors and biomarkers in different kidney diseases and by kidney and CKD stage. We don't know the importance of constellation of risk factors and biomarkers within different people and different phenotypes. And we don't know what the best value for therapeutic options is at different points in time, at stages of disease or diseases. And so, whilst our common goal is to prevent cardiovascular disease and kidney outcomes by identifying the triggers for early intervention, we are beginning to have more and more multidisciplinary approaches. We have multifactorial guideline recommended proposals to help us treat people. And we actually have got a little bit of it right, that it's actually about the care and about the people. And so this is a care model that Kathy Tuttle wrote about in 2020, so 4 years ago, which was also one of the last slides that one of you put up, that it really is about integrating the care and the understanding in a much better way, and look about patient-centered implementation. So, do I think that it solves our problems? Not really. I think the concept of cardiovascular-kidney-metabolic syndrome, which is a mouthful, recognizes the complexity of disease processes that currently impact a lot of people worldwide. It does offer an opportunity for collaboration in research, which I think is super important because we still don't understand all of these very complex interactions and the care paradigms. But I think as a staging system, it totally ignores the different etiologies of both kidney diseases and cardiovascular diseases, and that's disingenuous to the work that's going on in both fields. It's not simple to use, as Rob says, for clinicians or researchers yet, and it may inadvertently thwart research and validation efforts because of that non-understanding of the complexity and the need for diagnostic certainty. And so I think it's much better as a framework for education, and it needs to be tested in terms of utility. And if you actually read closely the summary, it actually says that. It says more guidance is needed on definition, staging, prediction strategies, and algorithms for the prevention of treatment. So I think they jumped the gun with the respect to the staging system. And I think that as nephrologists, we have right now a huge tension between inclusive frameworks, GDMT, and precision medicine, and how we time and individualize therapy, how we identify phenotypes within classification systems. We have lean diabetics, we have overweight non-diabetics, we have people with and without diabetes, and we have people at different ages and sexes, and how are we going to put all this complex information into a manageable working system? So that's one nephrologist's perspective, and perhaps it's shared by others or not. And again, thank you very much, and looking forward to the discussion.